So let's just have a look at this important aspect of a vessel that can be arising from below the base of an aneurysm. It is important because if you do not see it, you can lose it, and if you lose it, then you can have a stroke. Not a very pleasant thing. Now look at these angiograms. This shows an aneurysm which is arising from the base of the posterior communicating artery, and you can see that the neck actually gives origin to the posterior communicating artery, and this is only possible because of this 3D. It gives us the right working angulation, tells us how to plan, and now you can safeguard and do the procedure. And the next slide shows you that actually the aneurysm is fully coiled, but the artery has normal flow even at the end of. Here is another example where a 3D angiogram makes a huge difference. It's a patient who's got an aneurysm coming from the MCA trifurcation. There are 3 vessels that will be coming out on this point, and or very often 2 vessels, and unless and until we plan the treatment in such a way that this vessel is protected, we can lose this and have a very large territory stroke, which can often prove fatal, or if not, the patient ends up with a very large deficit. And this is the follow-up angiogram done after 6 months, showing no evidence of recanalization at all, with normal preservation of all the vessels. This is the same picture, the 6 months follow-up, showing us no recanalization and preservation of. The next thing is having a right working angle. Why is the right working angle important? It provides a good view of the junction between the neck and the parent artery, which is crucial. It is extremely important for us, because without it you can end up in allowing coils to prolapse into the main vessel. It demonstrates the origin of any vessel from the base. We talked about it. It also gives us a good profile of the aneurysm, which is again an important issue, because without that you cannot know whether aneurysm is going into the fundus or into the pseudoaneurysm. So here is the same picture telling you the right working angle. It shows us the profile of the aneurysm. It shows us the relationship between the aneurysm and the parent artery. It shows us also the takeoff of any vessel, if it is there, from the base of the aneurysm. Another point that we always evaluate, or we are always worried about, is the number of aneurysms. So it's important that we don't stop our study just because we see one aneurysm, but we go ahead and we study all the vessels in the brain, and if possible all 4 vessels, because without it you can never be sure that you have ruled out every aneurysm, because aneurysm can sometimes be multiple in patients. For example, look at this patient. This patient has got 2 aneurysms from the internal carotid artery, one in the posterior communicating artery region, and the other one is in between the posterior communicating and the ICA bifurcation. Another factor that one has to keep in mind while doing aneurysm is the size of the aneurysm. Why is the size important? It's important because the first coil that we place will be determined by the diameter of the coil. So if you oversize the coil, the aneurysm will rupture. If you undersize the coil, you can never really pack the aneurysm completely. And this again is possible by using a 3D angiogram or using a calibration technique which allows us to measure aneurysms. For example, here is an ACOM where the size is important, and we know the diameter. It was somewhere around 15 or 16 mm, and we know that the first diameter of the coil has to match this size. Look for unusual locations when you do not see an aneurysm in the expected location. These are important because you have a subarachnoid, and if you do not see this, you may end up with a problem. One of the locations, the distal anterior cerebral artery, where one may actually not be looking for an aneurysm in this region, and you may miss it and the patient can rebleed. For example, this would be a location, the distal anterior cerebral artery, and if you're not focusing on this area, you may miss it altogether, and the patient can have a second one or another one even more distal. Here is an example of a DACA aneurysm. You can see the location, and the 3D allows you to see the morphology, the takeoff of the vessels, and this is the end result after coiling, where you can see you coil the aneurysm and preserve the parent artery. Here's another example of a patient who had bilateral dark aneurysm on the left and the right side, and again the end result after coiling both sides. You can see successful coiling of both sides in unusual looking. Let's talk about another situation, very dangerous, and again a very friable aneurysm, which is a mycotic aneurysm. Now, what are the problem of mycotic aneurysm? They actually erode into the wall, and thus they are very prone to rupture and very dangerous to be left alone. What happens in a mycotic aneurysm is this: an embolus, which is infected, goes and lodges in an artery, can produce a distal infarct, and then it erodes through the vessel wall and forms an aneurysm. Thus we know that these are dangerous because this is a pseudoaneurysms, not true aneurysms, do not have a wall and are very prone to rupture. Here is an example of a distal mycotic aneurysm from a branch in the middle cerebral artery. This is the angio. The previous one was a 3D angiogram. This shows the microcatheter which has been taken into the vessel, and this is after we injected a drop of glue. And gluing is the best way to treat an aneurysm of a mycotic aneurysm in a distal location. This is a CT of the picture, like I said, who had a bleed after an infarct, and this patient has a much larger mycotic aneurysm. You can see that the whole vessel wall ceased to exist, but the late phases show leptomeningeal collaterals filling the MCA from the other side, and we know that coiling in this case is safe, because even if we take off the parent artery completely, which is the treatment of choice for mycotic aneurysms, the collaterals on the opposite side will take over, and this is what we show in the picture, the leptomeningeal collaterals filling the distal branches. And this is a CT taken a few days after coiling, showing there is no progression of the infarct at all. Here is another patient of a mycotic aneurysm. It's a young child, and there is a small little aneurysm which is 3 millimeters in diameter. 2 days later, you see the total change in the morphology in terms of size and shape, which is again classical for mycotic aneurysms. This is the end result of coiling, preservation of parent artery, and we have several follow-up angios to show that the patient continues to do well. The last thing we said was check the route, check the pathway to the aneurysm. Without it, again we can have problem, because we can never ever reach the aneurysm if the neck vessels are very tortuous. For example, in a situation like this where the neck vessels are extremely tortuous, we used a technique which is called the triaxial technique, where we have a guiding catheter in the neck, a coaxial catheter that goes through the neck vessel and comes right up to the distal ICA, and through that the microcatheter. So here is the picture, the 3 catheters inside, and the end result after coiling the patient, which shows very good results, and the patient is technically cured. Here is another patient where you have a very acute takeoff at the anterior cerebral artery, a very difficult loop to cross. How can you handle this one? What we do in this case is the combination of the tight loop in the neck and a tight loop in the anterior cerebral artery. Both can be circumvented by directly puncturing the carotid artery in the neck itself. So that's what we have done. You can see the catheter going through the common carotid into the internal carotid, and this is the coil mass that has been placed and the end result of coiling. Just a few words before we close on the choice of coiling. We have the regular helical coils, we have the complex coils, we got more complex coil and more complex coils. That shape itself would be determined whether the neck is wide, whether you want to make a better basket as the first coil. Then of course coils may be soft, they may be a little more stiff, and that would depend whether the aneurysm is ruptured and the size of the aneurysm. Then we got coils on which we have got active coatings. We can have a PGLA coating which allows you to promote some degree of fibrosis and fibroblast proliferation. We can have hydrogel coated coils which have an advantage that they swell up inside the aneurysm, and thus even if there's some space left, later on they pack and close the space completely. What are the complications? You can have a rupture if you do the case. You can have an occlusion of the parent artery because of a thrombus.